Hello, this is Elena Coucher. I will be discussing with you nursing management of the newborn and family, which will also include a newborn nutrition. So the neonatal period is defined by your book as a time from birth through the 28th day of life. For you guys to start understanding newborn assessment, it is essential that you first understand what is occurring with that newborn physiologically. I hope this lecture breaks this down for you. We're going to look at the systems. You might find that there are a couple of repetitive things throughout chapters 24 and 25. Transition to extrauterine life. At birth, the newborn must adapt to numerous physiologic and behavioral changes. Awareness of the adaptations provides us with the foundation for support to the newborn during that crucial time. You need to know that during transition, an infant undergoes many phases of instability, and that happens within the first 6 to 8 hours of life, meaning that there's going to be some ups and downs in vital signs. There's going to be some ups and downs in coloring. Adaptation, we call this the time of rapid change transition because the physiologic and behavioral changes occur quickly, very, very quickly during this time. And we have to be aware of what our expected findings. I don't ever like to say normal, especially within a newborn. So we're looking at expected findings or those things that we would not expect to find. It's crucial. We have to ensure that we identify early and do prompt intervention. The immediate assessment, your very first assessment as a nurse taking care of the newborn, begins in labor and delivery. It happens right as the fetus is born and enters this world and starts transitioning, and we're getting Apical scores. It's rapid. It is a rapid assessment. I know that Miss Martin has talked to you some about Apical scoring in her labor and delivery lectures. I'm just going to touch on it, but just know that that is the first part of the newborn assessment. Apgars are usually gotten around the 1 and 5 minute mark. If you're the nurse that's in labor and delivery, you're obtaining the Apical score of the infant. You are at the beginning. You're right there seeing what would be an expected finding on this newborn. So as you can tell, see here we have Apical scores. Table 23-1, I believe it is in your book. It assesses the heart rate, we're looking at respiratory rate, we're looking at muscle tone, we're looking at reflex irritability, and we're looking at color. These things are assigned a number value of 0, 1, or 2. 0, of course, if you think about it in terms of what 0 would mean, it's absent. There's nothing there. 1 would be slow, and 2, you're going to expect that this is a normal or expected finding. A score of 10 is possible. And guys, even if a neonate receives a low score initially, they can recover and score a much better one by 5 minutes. So newborns undergo phases of relative instability. They have different phases. They're all collectively called that transition period between the intra and the extrauterine life existence. We have a first period of reactivity, a period of decreased responsiveness, and a second period of reactivity. So now we're going to talk about these. Let's talk about the first period of reactivity. What is it? The first period of reactivity begins at birth and it lasts for about 30 minutes. The neonates are alert, they're moving, they're going to appear hungry. This is a great time to initiate breastfeeding. They're going to have myoclonic eye movements, spontaneous mural reflexes. They are going to actively suck, root, chew, and they're going to have some fine tremors. At this time, what you might see with your neonate that you're taking care of is their respirations are going to be very rapid and irregular. Heart rate increases rapidly from 160 to 180 beats per minute, then decreases after 30 minutes and might hit that 100 to 120 beats per minute. So during that first period of reactivity, we have respirations. We might auscultate those with the respiratory tract. We're going to auscultate that they might have fine crackles. There could be some audible grunting, nasal flaring, retraction of the chest may be very noticeable. That should cease within that first hour after birth, though. They cry, they startle easily, they have good head movement. Bowel sounds are usually auscultated at this time, and meconium may be passed. Doesn't always mean that it's going to be passed. Remember, it may be passed. A lot of newborns at this time will latch on the nipple and suck. In the first period of reactivity, as I said in the previous slide, it is a great opportunity and a great time to initiate breastfeeding if this is how the mother chooses to feed her newborn, particularly if the mom has chosen not to have any medications during childbirth. Um, I have an excellent video that I hope to show y'all in the classroom, which is called the newborn crawl. And it shows you how a newborn who hasn't had the experience of ingesting what mom has ingested, such as, having, baby gets some of the drugs that mom gets. So as she's sleepy, when neonates born, they're sleepy. So that's why some of them have a little bit more difficulty latching on, depending on what mom has had during labor and delivery. But like I said, I have a great video to show you about that. So during this time, they have a period of decreased responsiveness that occurs around 30 minutes to 120 minutes of age. And then this is that second stage of this period. Movements are less jerky, they're less frequent. Both heart and respiratory rates start to decline as a newborn falls into that sleep. Newborns are hard to arouse during this time. They have no interest in feeding. And it's a good time for mom to have that quiet time for herself and for baby and possibly do that resting. I talked to y'all in postpartum about how moms typically do not get a lot of rest. Once everybody finds the baby is here, what do they want to do? They want to come up and see mom and baby. But this is a great time for them to get a little rest and relaxation before all of the busyness of breastfeeding and newborn care start in. The second period of reactivity is when the baby awakens. They show interest in their environment. They're stimulated. It occurs between 4 to 8 hours post-birth, and it may last 10 minutes to hours. Their heart and respiratory rates increase. Peristalsis increases, so meconium is typically passed during this phase. They have increased muscle tone. Skin color changes. It's a good time for parents to ask questions about their baby. Babies' motor activity and muscle tone increases. If they pass meconium earlier, this may be the time that they pass more, or this may be the time that they pass it for the first time. We want to encourage a great interaction with mother and baby at this point. There does continue to be some complex changes occurring in the body systems, but the goal is homeostasis, which occurs minutes to weeks after birth. So the immediate adaptation, the most critical immediate adaptation and adjustment a newborn makes at birth is the establishment of respirations. Initial respiration is probably a result of a reflex triggered by pressure changes, noise, temperature changes, lights. Once respirations are established, then what we hope to see is that an expected finding of respiratory rate of 30 to 60 breaths per minute. We want to see less than 20 seconds of apneic periods. Signs of distress, we would see a respiratory rate greater than 60 or less than 30. Apnea that lasts greater than 20 seconds. If you notice any nasal flaring, retractions, or grunting, seesaw breathing, and that is the chest and abdomen do not rise and fall simultaneously. They're working harder to get air in and out, so they're using accessory muscles. Again, establishing airway is the number one priority for our neonates. The outer wall of the lung is lined with surfactant, and that's a protein. I think we've talked a little bit about it. I can't remember. It's manufactured by type 2 cells of the lungs. Surfactant keeps the alveoli open during respirations and prevents total collapse of alveoli during expiration. A term infant, they have adequate surfactants, so the first several breaths expand the alveoli and it prevents collapse on expiration. Crackles are normal at first, but should resolve during transition. Surfactant will lower the surface tension to keep alveoli open with less pressure. If they have decreased or no surfactant, there's going to be more pressure needed for inspiration, and they're going to get very tired very quickly. You see this a lot in preterm or sick infants. Priority nursing diagnosis would be impaired gas exchange and ineffective breathing pattern for those babies that are experiencing some respiratory distress. So we also need to assess quality with establishment. Breathing is related to diaphragmatic contractions, so they are obligatory abdominal breathers. It's a normal, expected characteristic of our newborns. This is because the infant ribs articulate with the spine at a horizontal versus a downward slope, so that inhibits the rib cage from expanding readily with inspiration. Infants who are born via C-section are at increased risk for some lung fluid retention. These infants are more than likely to develop transient tachypnea of the newborn. Newborn infants are by preference nose breathers as well. The reflex response to a nasal obstruction is to open the mouth to maintain airway. The response is not present in most infants until about 3 weeks after birth. Therefore, they are at risk for cyanosis or asphyxia that can occur with a nasal blockage. Upon assessment, auscultation of the chest, a nurse, what we expect to hear are loud, clear breath sounds. They're loud related to they have very little chest tissue that is present. So you just hear everything very well. So again, this is respiratory distress. I've already talked about it, so I will be skipping past this slide. However, you have it as a reference. Some common reasons that they might be experiencing some respiratory distress. You are looking at a slowed respiratory rate that may be related to analgesics or anesthetics administered to mom during labor and delivery. Apneic episodes that may be related to a rapid increase in body temperature, hypothermia, hypoglycemia, or sepsis. Tachypnea could be maybe a root cause that's related to inadequate clearing of fluid from the lungs or newborn respiratory distress. Maintenance of the O2 supply. The body knows what to do, and the pulmonary lymphatics will continue in the first hour to remove fluids. How does it happen? It's achieved because the pressure gradient from the alveoli to the interstitial tissue to the blood capillary is pressurized. It's a pressure gradient that does that. A reduction in vascular resistance also aids in accommodating this flow of the lung fluid. If lung fluid is retained, then an infant will not be able to maintain that vital lung oxygenation. Some factors that could affecting it include meconium aspiration, congenital diaphragmatic hernia, esophageal atresia with fistula, choanal atresia, congenital cardiac defect, or immature alveoli that can be either absent or decreased. Chest circumference is approximately 30 to 33 centimeters. Auscultation, we would expect to hear loud, clear breath sounds. They're going to see very near, and that's because the chest wall muscular is very thin. The ribs articulate with the spine and are horizontal versus a downward slope. That's because a newborn rib cage does not expand with inspiration as ours does. Their function is primarily a matter of diaphragmatic contraction. So abdominal breathing is a characteristic of newborns. So the immediate adaptation with the cardiovascular is what we see. The first breath initiates a series of changes from the fetal to a neonatal circulation. The rates, what we would have an expected finding, I'm going to use the word normal, but it's an expected rate of 120 to 160 beats per minute. Now that can vary. If your baby is upset, angry, screaming and crying, then you might count a heart rate of up to 180 beats per minute. they're also going to, within the first 2 hours, they're going to have some irregularities, and also it is affected by their sleep and their wake cycles. Systolic blood pressure usually between 60 to 80, diastolic 40 to 50. Their blood volume about 300 mils. The apical pulse in a newborn is at the impulse, rather, not the pulse. The apical impulse in the newborn is at the fourth intercostal space to the left of the midclavicular line. PMI is quite often visible as well as palpable, and the reason for that, I've already said, it's a thin wall, chest wall of musculature. You can just see, you can hear, you can feel everything. Apical pulse must be obtained on all newborns for 1 full minute, just like the respiratory rate. You have to do it for 1 full minute. So when do you think is the best time to obtain this? I want you to think about that. Um, and I want you to think about what you could do. And I think I've already said it in a previous slide, what you can do to aid you in getting this assessment on the newborn. It's a high-pitched sound, is shorter in duration, has greater intensity. S1 is louder and duller, and S2 is sharp. S3 and S4 are not assessed. Heart murmurs, if they're present, then we don't even consider them for repair or anything. Not considered pathologic until it's after 6 months. However, there's a big however there. If they're poor feeders, they're having apneic episodes, they're cyanotic, they have pallor, then the first thing that we're going to do is take and investigate these babies a little bit further, because there may be something more serious underlying going on with them. The thermogenic system is very, very important. Heat regulation is just as crucial for the neonate as establishing its respiratory and circulatory. Thermoregulation is the balance between heat loss and heat production. So you're going to hear thermoregulation a lot when we're addressing the needs of the neonate. The ability to produce heat mirrors an adult. However, in cold environments, the loss of heat increases during that transition time. That's why we keep our babies wrapped. Thermogenesis is heat production. Brown fat for them is rich in vascular supply. That's what helps them to maintain thermoregulation. Hypothermia, though, is common and it is very dangerous. Thermoregulation is the balance between that heat loss and the heat production. Adults will produce heat through shivering, but in newborns this mechanism is rarely operable unless they have been exposed to a cold environment over a prolonged period of time. A newborn can't shiver effectively to produce heat. It must produce heat in its fat stores. So that's why brown fat is very unique for them. It's usually present for several weeks after birth. It aids in increasing the metabolic activity in the brain, heart, and liver. It has intense lipid metabolism that can warm the infant by increasing heat production by 100%. It's a very important component. If they don't have brown fat, it's likely because they're a preemie or a low birth weight baby, so they are at extreme risk of ineffective thermoregulation. Now, babies can lose heat through 4 different modes of heat loss: convection, radiation, conduction, and evaporation. When you're talking about convection, you're looking at loss from the body surface to the cooler ambient air. If you're talking about radiation, it's lost from body surface to cooler solid object not in contact with the baby. So what if they're in direct line of the air conditioner draft? Conduction is going to be lost to a cooler solid object that is in contact with the body. So that's why we want to cover the scales before we weigh them or put them on any solid surface. We want to make sure it's covered with a blanket. And evaporation is going to be lost through conversion of skin water to vapor. That's why we like to make sure that before we bathe them, that they're stable. We want to keep their clothing and their linen dry. Now, cold stress. Cold stress is very serious, guys. They're going to have increased O2 consumption, which increases their respiratory rate. In turn, it's going to cause their pulmonary vasoconstriction and decreased O2 uptake to the lungs by the lungs. Peripheral vasoconstriction and decreased O2 to the tissues are a result of the increased O2 consumption and increased respiratory rate, which in turn increases the anaerobic glycolysis. And what that does is it decreases their PO2 and their pH, so they go into metabolic acidosis. So cold stress is very, very serious for our neonates. They maintain that heat primarily through a flexed position. The flexed position decreases the body surface area that's exposed to the environment. In normal infants that are not suffering from cold stress, O2 consumption and energy is used for maintaining their normal brain cells and cardiovascular functions. So in the cold stress infant, O2 and energy is diverted to thermogenesis for survival. So that's why you're going to see changes in their respiratory rate. They're going to be tachypnic in response to the increased need for O2, all leading to that respiratory distress. And in turn, it can lead to death. The fatty acids replace the bilirubin at binding sites in the liver, and it causes increased unconjugated bilirubin, and that's not water soluble. When warming the infant from that hypothermic state, the nurse needs to use caution. We have to warm them slowly. Now, I will tell you there are some fluctuations in book and practice. Typically, a newborn with a temp less than 98 degrees would be reswaddled and covered with another blanket to ensure their temp does not creep down. But the inconsistencies that you're going to see is they're going to say that a normal temperature within a newborn, a neonate is probably, I think your book says 97. I want to say it says 97.8. And I will tell you for testing purposes that I will use what your book states, but in practice it is different. So the complications from cold stress, they'll go into respiratory distress. If distress was already present, then it's obviously going to further aggravate it. It may reopen or cause the ductus arterius not to close. Knowing how the cold stress occurs and ways to prevent it, tell me what signs and symptoms you would see in a newborn. So you would see increased blank, and what would their color be? What would you expect it to be? You're going to see an increased respiratory rate, and their color is going to be mottled in appearance. I just want you to think about it. Also, what do you think their activity level is going to be? How do you think that baby is going to behave? A cold stress baby, you're not going to see in that flex position. A cold stress baby, you're going to see them laying out flat. They're probably going to be flaccid. Those are some dangerous things. We have to be able to assess, and we have to intervene appropriately with our moms. So with temperature regulation, heat stress, sweat glands at this time are not functional. It will cause, if they get too hot, it can cause a possible heat stroke, dehydration, or even death. Prevention, parenting, teaching. That's the biggest thing. Typical within normal limits, temperature of an infant is 36.5 to 37 degrees Celsius. And this is where I said you're going to see a little bit of fluctuations or inconsistencies in the book. I will only test you by book. They're saying that a normal temperature is 97.7 to 98.6. In the hospital setting, we will let our babies stay 98 to 99. If they fall below 98, we're probably going to put another blanket on them. If they get above 99, we're going to take a blanket off. We're going to check their temperature under the arm. We're going to use a temperature probe as well. Hematopoietic, the hemoglobin is 13.7 to 20.1. With an average of 12 to 20 at 2 weeks. Hematocrit 51 to 56, and 8 weeks you're going to see it 39 to 59. Iron stores last approximately 5 months, so brief anemia is not too serious. so it's not treated. Increased WBCs the first day, 23 to 24,000 after birth, and then it falls to 12,000 for the neonatal period. Infection is usually marked by decreased WBCs and decreased neutrophils. Serious infections are not well tolerated by newborns, so leukocytes are slow to recognize foreign proteins and to localize and fight infection early. Sepsis may be accompanied by a concomitant rise in the neutrophils, but some neonates may only present with clinical signs of sepsis. Clotting factors are decreased during the first few days of life because there are no intestinal bacteria to produce vitamin K. Newborns cannot synthesize vitamin K, so coagulation factors are synthesized by the liver and are activated by vitamin K. A newborn has sterile bowels, so they cannot synthesize that vitamin K, and it results in a transient coagulation deficiency by the second and fifth day of life. So, therefore, knowing all of that, what do we do to intervene for our neonates? Within the first hour of life, we administer aquamaphytin IM, vitamin K, to the newborn until it starts eating and bacteria starts to grow in the gut. Cord blood samples can be also obtained at birth and establish the type and RH factor for newborns. So now we need to talk about leg clamping. This is defined as greater than 2 minutes post-birth before they actually clamp and cut the cord. It's supposed to expand the blood volume. It's like a placental transfusion. Your book discusses the benefits that have been recently identified with it, but I thought it was worth mentioning that some of the previous identified complications identified with leg cord clamping. So polycythemia, hyperviscosity, those are some things that we've seen in the past with it. Plethoric or ready red appearance. There's been some research that it gives them a sluggish circulation, which could lead to emboli in the microvascular respiratory distress or hyperbilirubinemia. But it also has, from what I have read, is some benefits which would give them prolonged effects of prevention against anemia. So I'm just mentioning it because it's worth mentioning. It might be something that you would see on standardized testing. So what happens with the renal for the baby when they're born? They have limited ability to concentrate urine. They have normal number of voidings, 6 to 10 per day, which is something that we want to teach moms and dads to note when they go home. Urine is pale straw color. Also normal is cloudy and pink tinged. The newborn normally loses 5 to 10% of their birth weight. It does return to within normal range within 10 days. They can easily become dehydrated since they cannot concentrate urine. They should void hopefully within the first 24 hours to establish the patency of the urethra. They lose fluid from urine, feces, increased metabolism, limited fluid intake. And you need to make sure that when you're doing a neonate assessment, that we're looking for any palpable masses in the abdomen. Usually they'll be noted in a renal region of origin. Gastrointestinal, the full-term newborn swallows, digests, metabolizes, absorbs proteins and simple carbs, emulsifies fat. We'll discuss some nutrition towards the end, though. They have mucous membranes of the mouth are moist and pink. They have hard and soft palates that are intact. Hopefully, this is something that you want to assess. Moderate to large amounts of mucus are common in the first few hours after birth. Epstein pearls may be found in the gums. Those are some small whitish yellow areas that appear in 1 to 2 weeks. And they have full cheeks and they have well-developed sucking pads. So remember, we're looking at the normal newborn. In utero, a fetus will have practice sucking motions. After birth, these motions are put into practice with a coordinated effort to suck and swallow and breathe. Sucking post-birth may be affected by pain meds the mom receives during labor. They'll suck and burst of 3 to 4 sucks at a time. Whether they do breast or bottle, the nipple needs to be placed well inside the baby's mouth. due to their inability to move the food from the lips to the pharynx. Teeth can develop in utero, but typically are not erupted yet. However, occasionally a neonate will be born with one or more teeth. Bacteria, I've already talked about, are not present in the GI tract at birth. Anal and oral orifices permit entrance of bacteria and air after birth. Normal colonic bacteria is established within the first week. Normal intestinal flora aids in synthesizing vitamin K, folate, and biotin. Bowel sounds are present soon after birth. Their stomach capacity does vary upon infant size. Immature cardiac sphincter and nervous control creates an atmosphere for easily regurgitating whatever they have ingested. To prevent regurgitation or spitting up, we don't want to overfeed the infant, and we want to burp them frequently. Gums, things that you should notice on a normal newborn is they're pink, they're moist, they have sucking pads, they do suck, swallow, breathe, and that depends on neuromuscular development. Sometimes you find infants that have difficulty with it even when they're full term. Bowel sounds are present soon after birth. Their stomach has again, it's going to be dependent upon the size of the infant, but 30 to 90 meal capacity is within normal range. Digestion, stools, we want to see meconium in the first 12 to 24 hours. Third day, they should have transitional stools, so it's going from meconium to more of that, formula or breast milk based. And the fourth day, they should have a milk stool. They can digest, of course, the simple carbs. They have a limited ability to digest fats because they don't have a lot of pancreatic enzymes. Proteins almost totally metabolized for growth. They establish patency of the anus and GI tract, and how we do that is with meconium passage. That is one way that we assess that. I expect when y'all are doing your newborn assessments, when you are talking about the anus, that you are stating that it's patent, and it is patent as evidenced by meconium passage. If you tell me it's patent, then I'm going to question you how you know that. Did you assess that? And if you did assess that, tell me how you assess that. These are just some pictures of some stools that you're going to see. What I say, we got the first. Sometimes the meconium plug is present. If they haven't had a stool, we might stimulate them to have a stool once with a temperature probe, just not the probe, but the cover. Sometimes we'll have to stimulate that and get that plug out, and then they'll start stooling. Umbilical cord, 3 vessels, one very large, three vessels. They have 1 vein and 2 arteries. They have bowel sounds that are typically present within 1 to 2 hours after birth. Palpation of the abdomen, we're looking for hepatosplenomegaly. We're looking for renal masses, and we're assessing whether they have an umbilical hernia or not. Remember, no vitamin K in the bowel, therefore no stimulus for the liver to produce clotting factors. So at birth, the neonate is cut off from maternal glucose supplies. Feeding helps to stabilize them. Within the first 24 hours, we'll see rapid depletion of glycogen supplies in infants. Eventually, at about 3 days of age, it'll stabilize. So hemoglobin is also broken down and converted to indirect and unconjugated bilirubin, which is insoluble and can leave the vascular system and permeate out to the other extravascular system. The liver has to be able to convert that indirect and unconjugated bilirubin to direct conjugated to make it water soluble. That way it can be eliminated through their urine and feces. When the liver does not do this fast enough, such as if it's immaturity, premature, increased hematocrit, birth trauma, or bruising, then bilirubin will permeate to the other tissues, and it causes that jaundice color, and we call those babies hyperbilirubinemia babies. Neonatal hyperbilirubinemia, it will appear after the first 24 hours and disappears by day 7. Signs and symptoms that we're going to see, they're going to have a yellow sclera, yellow mucous membranes, thorax, abdomen, extremities. It's normal unless it's elevated to extremes. 50% to 80% of all full-term infants are visibly jaundiced during the first 3 days of life. 80% of preterm infants develop neonatal hyperbilirubinemia, especially very common in Asians, Native Americans, and those from Alaska and Eskimo. It's a head-to-toe appearance. Level of indirect bili will be at about 5 to 7 when we start to notice that they're getting a little yellow. They need treatment after 10, definitely by 12. Phototherapy with ultraviolet light breaks down the bili into tissues. We want to make sure the infant stays hydrated. Bili still is in the blood until it's deposited in the tissues. So we have to be able to get them to excrete that in the urine and stools. What if we see jaundice at less than 24 hours? Well, we're going to do some stat treatment on them. Um, that this is what I say. And now, if you have a baby with a bilirubin level of 20, it can result in some brain damage. Enough bili has left the blood to interfere with brain cell synthesis at this time. But I have to wonder if there is just some kind of mechanism. Babies that are breastfed do not break it down as fast as those that have formula. And so, what did we do back 100 years ago? 150 years ago, 200 years ago, these moms would deliver babies, and then what would they do? They would go back out in the fields and keep working, and they would take their newborn infants with them. So, I just wonder if that was there was some kind of mechanism there that, you know, it's what we did, and it prevented this from happening as much. Or maybe it did happen, and they just maybe they dealt with it and they just kept feeding and they kept putting their baby in indirect sunlight. I don't know. I can't tell you the exact reasons, or exact way that things happen, but I have to wonder if somewhere within our system, somewhere within our memory cells from the beginning of time, we dealt with hyperbilirubinemia, and it was some kind of mechanism of protection. I don't know. That's just my way of thinking. They get passive immunity from mom. We uh, we take care of them. We vaccinate them within 12 hours after birth to protect them from Hep B. Cells that provide newborn with immunity develop early in the fetal life but are not active for weeks to months after birth. Birth to 3 months, they receive passive immunity from mom. And if they breastfeed, this continues and they continue to receive that passive immunity. Integumentary color is appropriate for ethnicity. Pink mucous membranes, they have Vernix caseosa. That's a whitish substance covering the skin at birth. It's cheesy, it's odorless, it's protected from damage in utero. We do delayed bathing now. We let the Vernix stay on there because it's a protective factor for the babies once they're born. So delayed bathing is one of those big things within healthcare right now. Creases on the palm and soles. The more creases, the more mature. We look at the simian crease. Caput saccudineum is edema of the scalp due to pressure during labor and molding. You were going to see these terms along the way, and you're probably going to see these terms on your exam. Cephalohematoma is the blood between the skull and the periosteum. Desquamation is peeling skin. Milia, it's very normal, small white immature sebaceous glands. Mongolian spots, those are bluish to black pigmented areas across the buttocks. Those are fade in most infants. We see them more often when we're taking care of the African American baby, and some other nationalities as well. Um, you have different types of birthmarks that you could see. A stork will blanch easily, but it will fade. You'll have the nevi, which are the birthmarks. You'll have a strawberry mark, you'll have port wine stain. Erythema toxicum, that's a transient rash and lesions of various stage. It can have macule, papule, vesicle. Those are very normal. Edema, usually they have generalized edema, especially to the hands and feet. Infants of diabetic moms, though, do have more edema. You'll see visible blood vessels, but there'll be few at term, and you'll probably see a lot of them towards the abdomen. The breasts are swollen due to estrogen from mom and in both sexes. They can have whitish discharge. We'll also want to make sure that when we're assessing them that we're not seeing an extra nipple. That can be, we call that an accessory nipple, and it can be present in both male or female. The more mature the baby, the larger the breast buds. With the female, the external genitalia is enlarged. Labia majora is covering the minora at term. And it's not uncommon for them to have some pink discharge um, because it's estrogen related, and it's eliminated, and then it decreases. With male estrogen influence, they're going to have some pigmentation. The testes should be descended. You'll see rugae. That's it's on the scrotum. That equals a more mature male infant. And we also need to assess the urethra and ensure that it is at where it is supposed to be positioned. Many times, not many times, but babies can be born with hypospadias, where the urethra is on the inferior side of the penis. There are different degrees to hypospadias. You the most severe variant of it is proximal hypospadias, and that is when it is at the base of the penis, right at the scrotum. Skeletal, the head is the largest part, approximately equal circumference as the chest. You're likely going to see molding, and sutures are going to overlap to decrease that head size or shape to fit through the pelvis. Microcephaly is when we're going to see babies born with a head circumference less than 32 centimeters. This could be disease, or it could be just something genetic. Microcephaly is greater than 4 centimeters of the measured chest circumference, so we're going to suspect that these babies have some hydrocephaly going on. Fontanelles, that's the space between the skull bones. Anterior is diamond-shaped junction of the parietal bones with the frontal. Posterior, triangle-shaped junction of the parietal bones. The sutures are cartilaginous. They become ossified after full brain development occurs. You should not see any of the fontanelles bulging. We do not want to see them full, and we do not want to see them depressed. The spinal column normally has a C curve. You should be able to walk your fingers down the spinous process of the vertebrae. You don't want to feel any bulging or missing bones, pouching, dimpling, discolorations, open areas. Those are all abnormals. The hips, you inspect the buttocks. The number of skin folds should be equal bilaterally. Ortolani's maneuver is developmental and congenital hip dysplasia and dislocation assessment. You should hear an audible click. Of course, we're not going to ask y'all to do this procedure in the clinical setting, and I know Miss Martin talked to y'all a little bit about that through the musculoskeletal. Legs, fingers, and toes. Occasionally, babies are born with extra digits. It happens. It's kind of creepy. I won't lie. And usually what ends up happening is they'll tie it off, and they'll leave it tied off, and that digit will die off and fall off. I know it sounds awful. We look at simian creases. That's a continuous line across the palm of the hand. That is frequently associated with a Down syndrome baby. This is why we're doing a full-on assessment. With the eyes, ears, and nose and mouth, the eyes, the placement, they probably will not have tears or discharge at this time. Occasionally, you have babies that are born with some ucky discharge. You want to put some gloves on when you're touching those babies because you just don't know what they came through. The lens should be clear with red reflex, pupils equal and reactive, movement random. The nose, we look at symmetrical, no drainage. Patent nostrils, how would you do that? How would you assess the patent nostril? You need to be aware because they are nose breathers. If they're not breathing through their nose and they're looking a little bluish, you probably want to get a pulse ox on those babies. But normally what you're going to see is it's symmetrical. What you're going to see is that they're definitely breathing through there. And of course, you were looking for nasal flaring also when you're looking at their nose. Their ears with symmetry, the cartilage rebounds when bent. Hearing is similar to an adult, but we'll do a hearing screen in the newborn nursery. The mouth, we assess the palate, we elicit the suck reflex. Neuromuscular, they'll have the sucking, rooting, grasp, the Moro and startle reflex, Babinski, stepping, walking, and tonic neck. I have definitions for these on here, but my whole goal is that I'm going to show y'all a film in class next week whenever we're in the classroom that'll show you these reflexes and how we assess them. LGA, AGA, LGA, and SGA appropriate for gestational age, large for gestational age, or small for gestational age. You need to know these percentiles and how you would assess those infants. If you see that it's an LGA infant and you see that mom delivered an LGA infant, you know that not only is she going to have some problems, but the LGA infant might actually have some, as well as the SGA. So you need to know what percentiles that they fall in, and you need to know some risk factors that are associated with each of them. Now, many of you have been in the clinical setting, and I did some clinical a couple of weeks ago, and we were talking about the Dubowitz and Ballard scores. This used to be done in the nursery, and we would have it done on a form. This is always done on the computer now. So it's a neuromuscular maturity. It's a level of the CNS maturity and it reflects in the reflex development and sleep-wake cycles. We look at physical maturity as well, and it's accurate to plus or minus 2 weeks. Now you can also see this in your textbook, and but the next slide we're gonna talk a little bit about that. Uh, but infants born at risk for gestational age and weight problems will exhibit some physiologic and pathologic states related to degree of maturity. So that is why we do the Dubowitz and Ballard scales. We look at posture. We observe how the infant lies in the crib. The more flexed the extremities, the more mature. We do square window, where we flex the wrist over the posterior forearm. The smaller the angle between the hand and forearm, the more mature. Hand is flexed over the forearm between your thumb and index finger. Again, we're going to see this on a film. The arm recoil, flex for 5 seconds, fully extend. They should have a very brisk flexion and recoil. The tighter the recoil, the more mature the finger more mature. The popliteal angle, we hold the hips flat to the crib. We flex the knee onto the chest, holding in place. Take the other hand and extend the leg with the finger toward the head. And then you want to measure the angle behind the knee. And again, the more mature, the smaller the angle. Scarf sign is when we grasp the hand and pull around the neck. We need to note where the elbow rests on the chest. The less distance the forearm can be pulled, the more mature. So this is why we're looking at this. If we're told that this baby was born at term, however, our Dubowitz and Ballard scores are showing that they are less than what mom was reporting that they are, then we might have a baby that we need to assess a little bit further. How premature are they? So these are important tools. We look at physical maturity because we look at skin. We want to know how much, thickness and veins. We need to make sure that they're not peeling and cracking, because that equals that they're more mature. They stayed in utero a little too long. With lanugo, the more lanugo that they have, and that's a little fine skin. So the more lanugo, the more premature they are. We look at plantar surfaces. We want to look at those creases. We look at the breast. I just talked about those. We look at the eyes and ears, the genitals, and then you total the numbers and you rank each category and compare your score to the week's gestation that's reported. And here is the Dubowitz and Ballard score. This is just a chart that shows you. And I don't know if y'all have one in your paperwork or not. I'll try to get my hands on an old one and pass it out to y'all. Sensory behaviors, vision accommodation is not present at birth and gradually improves from birth to over 3 months. Response to movement, shining a bright light will have an infant following it visually. Clearest visual difference at birth is 20.3 to 30.4 centimeters, so 8 to 12 inches. This means as mom breastfeeds, she's at the perfect visual distance for the newborn. Hearing requires amniotic fluid to drain first, but then once it does, the infant will have hearing which matches the adult. Before discharge, again, we're going to do a hearing test that we'll do that in the nursery. Approximately 1 in 3 in 1,000 normal term infants will have bilateral hearing loss. And infants, they respond lovely to mom's voice. They know mama's voice. Smells, newborns react to strong odors. Breastfed infants can smell breast milk, thus they can differentiate their mother. I told you I was going to show y'all a video, and this video is the newborn crawl, and I think I have it on here, but I also have it in my mini lecture, because what they have now figured out is that the areola has a similar smell as the amniotic fluid, so that is how the infant knows to make their way to the breast, how they know to find their way there. Um, this is just some nursing care. What we're talking about is some nursing diagnoses: ineffective airway clearance. We have to get excessive mucus out. You have to learn how to use the bulb syringe. You depress in the middle. You put it up to the nose, and you suck it out. Sometimes we have to delete these babies and suction out their stomach. Because they're unable to clear it out of there. We need to make sure that we're auscultating and listening to these babies. Impaired gas exchange is another nursing diagnosis that we might also see. Ineffective thermoregulation is definitely one. Signs and symptoms: increased respirations, cyanosis, skin. We want to do skin-to-skin contact. Cover with pre-warmed blanket. We want to cover their head too. We want to make sure they're dried thoroughly. Radiant heat panels at 37 degrees. Skin probe on the abdomen and check the temp every hour. Babies are also at risk for infection. Now, not just we do ophthalmia neonatorium, erythromycin to a lower conjunctival sac within 2 hours after birth. That is to protect against chlamydia and gonorrhea. Does that mean that every mom has it? No. Another area of infection that we have to be aware of, we have to teach our moms to fold the diapers down below the umbilical cord. We do not anymore add alcohol to the cord for drying. And I think your textbook doesn't, so I will not be testing you over cord care because sometimes, and I think Baptists may still do it, I cannot remember, but we used to do triple dye to the cords, and I think there's been some evidence-based practice over the past few years that's come out, and we don't triple dye them, and nor do we put alcohol to them. But we do want to make sure that we diaper down below that so that no pee-pee gets up there and they do not get an infection in their drying cord. Nursing care, they also have a potential for hemorrhage because of lack of vitamin K for several days, and that's why we give aquamaphytin IM. We do this in the vastus lateralis within 2 hours of birth. They do have potential for jaundice, that jaundice color. It is called hyperbilirubinemia. It is not normal in the first 24 hours. We have to assess their skin for blanching, head to toe. If they have centralized jaundice to the abdomen, the bili is too high. It does peak at about 6, around 72 hours. They also are at risk for a potential for hypoglycemia. The newborn abruptly loses glucose supply when the cord is cut. Signs and symptoms you're going to see: cyanosis, apnea, jittery, they're going to be lethargic, high-pitched cry, twitching, seizures, eye rolling, and sweating. If the infant of a diabetic mom is LGA and they're greater than 4,000 grams, they might have to have received D5W in labor, then we're going to check finger stick blood sugars within 30 minutes of birth on these babies. 35 to 40 is the lowest, and we need to feed them, or we're going to need to gavage feed them. PKU, it's an inborn error of metabolism, genetic disorder where missing enzyme causes a buildup of phenylalanine, which causes severe mental delays. States do regulate the screening test for all newborns. It doesn't matter. Everybody gets it done. If the levels increase, the levels will increase after food is introduced and the missing enzyme prevents metabolism. So if we can't draw a lab through the vein, we'll do a heel stick after 24 hours on a vaginal delivery and 48 on a C-section. Discharge planning, new parent teaching, circumcision care, temperature taking, respirations, and we want to protect them from environment. I've gone over temp. I'm not going to go over that again. Circumcision care, we're going to do Vaseline gauze. We're going to watch for bleeding, signs and symptoms of infection. Keep it clean. Rinse the diaper wipe in warm water to cleanse the area after they've stooled or voided. Respirations, we want to talk to them about if their baby has some apneic or tachypnic episodes. We want to put them prone or side lying to sleep. We don't want to use any talcum powder. They are nose breathers. We want to remove pillows and thick blankets because we don't want them to suffocate. Also, newborns experience rashes. They can have the newborn rash or a diaper rash. Cord care, we do not alcohol that anymore. Sorry that is still in there. I always mean to take it out. Bathing, a sponge bath until the cord falls off at 10 to 14 days, or the circumcision is healed. We want to avoid cold stress. Best way to check temperature of water is with a thermometer. The parents need to be alerted to what infant cues and clues are, what to do for crying. We also need to talk about car seat safety. We need to make sure it's a federally approved car seat, they're rear facing, back seat installation, and they actually do suggest, one of the recommendations is that they are rear facing till 2 years old. You want to make sure there's no airbags in the area of the seat. You need to know the laws and safety, and they must have a seat to go home. They can't go home with their baby unless they. When we're talking about transitioning to parenthood, the process, the sequence of events, they're kind of interrelated and interdependent. And that's where they've become, we're not just two separate people married to each other. They become a family at that point in time. It is an adjustment. So, we also, it occurs to anyone and everyone that decides to have children, whether you're a 20-something, 30-something, teenage couple, homosexual couple, or adoptive couple. It's a different way of viewing your life. Parenthood can serve as a maturation factor for both men and women. Historically, parenthood was viewed as a crisis. It's currently seen as a developmental transition rather than a major life crisis. It is a transition, like I said, what was to what is to be. Dads sometimes feel jealous or inadequate. Mom spends all of her time with the baby. Dad wants to do more. Dealing with a crying infant also can be stressful and emotional for new parents. On the other hand, it's rewarding and allows parents to develop and display a selfless, warm, and caring side. What do you, the nurse, do? You need to make sure you have open channels for communication, anticipate new needs, highlight potential gains that will occur. The parent comes to love and accept a child, and the child comes to love and accept the parent. This is also known as bonding. This is what we want to see with the mom and the dad before they leave the hospital. It usually is a period that begins shortly after the birth. It's important for mother and infant to develop that attachment. Parenting actually starts before the birth. The fetus is aware of and responds to external stimuli. They know mama's voice, I'm telling you. Fetal attachment and interaction with the infant starts before the birth. Both will feel the baby kick. Both can talk to the baby. Hearing develops at 24 weeks in gestation, so it definitely was going to know that mom's voice. Nurses, we have to assess whether or not bonding is occurring. Call the baby. They need to call the baby by name. If they call the baby it or baby, I'm going to start being a little concerned, especially if we're leaving the hospital. And now maybe let's think about this. What if we have a baby that's born and it was supposed to be a boy or it was supposed to be a girl, so they're leaving the hospital unsure of what they're going to name this little boy when it was supposed to be a girl. I can understand that one. We're narrowing it down to this name or that name. But if we're seeing a patient in the clinical setting, maybe we're working in a clinic and they're 6 weeks out and they've yet to call their baby a name, I'm going to start to worry a little bit. We want to look for signs of bonding. We want to be alert caregivers that we talked about attachment in postpartum, and we talked about what we might expect from postpartum depression. And those are some of the things that kind of go hand in hand with the newborn and that and postpartum depression. Circumstances that influence it, events in the pregnancy or birth, maybe their expectations were not met. Maybe it's just that they had a rough delivery or they had a rough pregnancy, and so they're not bonding as well. We have to be alert and we have to intervene if that's what we're seeing. And what about fathers? Rooming in gives increased time and confidence to both mom and dad and siblings. Fathers do have a significant impact. Their expectations may not match the reality of parenthood. The image of father starts to develop, and then you want siblings to visit and see it firsthand. Some nursing interventions. We want to teach infant care when the father is present, especially if they've not had any children before or if they've had a girl before and now they have a boy who's had a circumcision. Make sure that both are present for the education. We encourage fathering classes and we give anticipatory guidance. Uh, I would love if our facility did postpartum phone calls and visits, but we don't do that. Health departments do, but they mainly start seeing those that are at risk. Studies show that men do get stressed and depressed as well as women. So, infant states and cues, we're wanting to look at parent-infant attachment. It does affect both parents and infants. It promotes a loving relationship. It improves infant development and they develop a healthy self-image. So we want to make sure that mom and baby and dad and baby are attaching appropriately because we want to see that they have this helps set them up for better relationship life. Cue sensitivity. Documented as origin of parent-infant attachment, involves recognition of individualized infant body language and provision of an appropriate response. Parents who are sensitive to their infant's needs and who respond consistently and appropriately foster a mutually satisfying reciprocal interaction. And that leads to that healthy relationship. We want to incorporate info about infant states, cues, and behaviors into any prenatal education. And we want to make sure that we give it in postpartum teaching as well. Infants have sleep-awake cycles, and they go from deep sleep to crying. It's just one of those things that happen. You think, oh my goodness, this baby, they were sound asleep and all of a sudden they're screaming. The single most important element for understanding an infant's response to the environment is knowing that they do that they have those. Um, it is imperative that we do an appropriate response to the infant needs. I don't know how anybody else has heard. I'm sure quite a number of y'all have children in the classroom. Um, but one of the things that I've always heard said is, "Oh, you're going to spoil that baby by picking that baby up." But you know what? This baby is crying because it has a need. So if you do not respond to that baby's need, then they're not going to develop a trust relationship with the parental figures in their life. So when the baby cries, you need to go to the baby, and this is things that we need to teach them. You need to go to your baby. Your baby crying signals that there is a need, whether it's to be changed, whether it's to be fed, or whether it's to just be held. It's still a need, and it's a trust relationship that the infant is starting to develop and build with the parents. So again, I'm sorry, the deep sleep and the light sleep, I got off on going to the infant needs. But newborns sleep about 16 to 18 hours a day. First few weeks, they have wakeful periods. They seem dictated by that point by hunger, but soon they start having a need for socialization. By the fourth week, babies will stay awake from one feeding to the next. And it swings. It can go either way, and in 60-minute cycles. Breastfed babies typically wake up a little more often to nurse. Breast milk is digested so quickly and so easily that um, that's what ends up. That's why they wake up and they're wanting to eat more often. When they're drowsy, it can go either way. Speak to the baby or pick the baby up. They might wake up. If you pat or leave them alone, they might or rock them, they might go back to sleep. It's kind of the things you just need to teach the moms and dads. Every infant is different, so you can't really determine what one wants over the next one. You just have to go to them and attend to their needs. Their quiet alert phase is perfect for interaction, teaching, and feeding. Cues, the active alert is a subtle cue. This is when we're probably going to want to start interacting or maybe getting to the point that they're wanting to eat. So we have hit the newborn nutrition part of this lecture. Due to time's sake and the fact that I know that you guys do not sit at home and listen to a lecture for an hour and a half or 2 hours, I will be coming into the classroom and I will be presenting my mini lecture over the normal newborn and assessment. But I decided I will be presenting the newborn nutrition lecture in the classroom as a face-to-face interaction. Um, so we will have a lot that we're doing in the classroom that day. I hope that you all will attend, and I will see you there.